Hey everyone, Khalid here. Welcome back to Clinical Physio. Thank you so much for joining us for another case study. This patient has knee pain. If you enjoyed this video, if you like your case studies, please be sure to smash that like button. And otherwise, let's dive in with this patient's subjective history. So we have a 39-year-old female patient who's presenting with a 2-week history of knee pain. We can see that she started experiencing her pain when she fell directly onto her knee whilst playing hockey 2 weeks ago. When she did this, she felt immediate pain and swelling at her right knee and she was unable to play on. Clearly a significant injury. She went off the pitch and didn't recover. Since then, she's been finding that she's been having increasing problems with her knee. She's been finding that she's getting some giving way, a feeling of instability, but no locking at her knee. But she has found that the pain has improved, which has led her to suspect that maybe this isn't such a serious injury after all, and she's asking you whether she can start to think about going back to hockey. So next, let's go through the objective examination, and there's quite a few things to discuss here. First of all, we look at the patient's gait. Now, she doesn't need to use any walking aids in order to walk within your clinic, but there seems to be an element of a limp there when she is walking. You go to palpate her knee, and in particular, you're looking to palpate along the joint line to see if it's painful, but actually there wasn't any pain on palpation of the joint line. We look at her range of movement, both at the hips and the knee, and largely her range of movement was pretty good. She has full range of movement of her right knee, and whilst there is an element of pain towards end range flexion, it is possible for her to achieve full range of movement. So as a result, you decide to do some special tests. We have varus and valgus stress tests. Both of these were negative. You look to do a Lachman's test, which seems to throw up a little bit of a curveball. It seems like there is a little bit of excessive movement when you're doing that test. You then try and compare this with an anterior draw test, and whilst again it seems like there's a little bit of excessive movement, it's a negative in terms of increased anterior tibial translation compared to the other side. What we do see, however, is a couple of positives on some other tests. There is a positive with the posterior draw test and a positive with the posterior sag sign. What do you think is going on here? This is your opportunity, ladies and gentlemen, to pause the video, write down what your thoughts are about the diagnosis, and join us again where we'll go through the answers and all the clinical reasoning. Okay everyone, time's up. Let's go through the answer to this case study. So, with the presentation and in particular with some of those special tests, it was evident to us that this patient had suffered a posterior cruciate ligament tear. Why was this? Let's go through all the answers. So first of all, if we take the history behind this patient, she had this hockey injury. It was very evident that it was immediate pain and immediate swelling as soon as it happened, and she was unable to play on. Both of these signs indicate, first of all, that this patient has had a serious injury to the knee, and one of the key concerns would be a fracture. Normally, a patient like this would probably go to A&E, have an X-ray, which would rule out a fracture, and thankfully that was the case for this patient. But therefore, the second thought process we have would be on a significant soft tissue injury. And the fact that this patient had this sudden pain and swelling, the fact that they couldn't play on, and the fact that she's been experiencing some giving way since, all points us in the direction of a ligament injury as a first suspicion. When we look at the actual mechanism of injury itself, when you have a posterior cruciate ligament tear, the way that this ligament most commonly gets injured is when the tibia is pushed back relative to the femur. And for this particular patient, when she had fallen on the hockey court, and the fact that that means that falling onto the anterior knee can push the tibia back onto the femur, meaning that you get that posterior tibial translation injuring the PCL. Then, what about those special tests? Because we had a couple of curveballs with the anterior cruciate ligament testing. We had excessive movement on the Lachman's, we seem to have some excessive movement on the anterior draw, and we had positives on the PCL tests as well. When you have a patient with this kind of injury, always do your PCL tests first. The reason being is that if you're doing your anterior cruciate ligament testing, your Lachman's test and your anterior draw test, you can get fooled into thinking that there's excessive movement here, there must be an ACL injury. But instead, what we're doing during those tests is pulling the tibia from a posterior position back to the middle. And it feels like there's excessive movement as a result compared to the other side, but it's not because the ACL is torn, it's because the PCL is torn. And once again, because it's sitting so far back, it means that we're pulling it from posterior back to the middle. If we do our sag sign test first, it helps us to find out, first of all, is there a PCL injury or not? And with this particular patient, because you do the posterior sag sign, as you can see on the screen here, and you see that there's a drop in the affected tibia compared to the other side, that automatically tells you that the PCL is first implicated. And then when you do your ACL tests, it makes sense as to why there's excessive movement, and then you can just look to see if there is excessive anterior translation of the tibia compared to the other side. So effectively, for all those reasons, it was apparent to us that this patient had a posterior cruciate ligament tear. So what do we do about it? Well, the first thing to do is to consider whether we treat or refer on. Now, lots of patients might decide that they don't want surgical intervention. However, I would out of habit tend to refer this patient on for an MRI scan so that you can get a definitive answer on whether the PCL is torn or not, and if there are any other structures that are affected. That is sometimes a reason that is missed when patients are not referred on for MRI scan. They just look at the PCL, say, oh, it's only the PCL, we know what's going on. It's always important to look at other structures as well. For example, the posterior lateral corner could be affected, and that would almost certainly require surgery if the PCL is torn as well. So it's always important to refer on. You can always do some basic exercises with the patient in the meantime. For example, there's no reason why we can't start this patient off on some basic quadricep strengthening exercises like a straight leg raise, inner range quads. We can get some glute muscle exercises in there like a side lying abduction or a prone extension. We can get the hamstring started with some resisted knee flexion. We can do those exercises in the meantime, whilst they're getting their scan, to see whether or not we can start some early strengthening and see what the patient wants to do once the scans come back to make a decision on surgery versus non-surgery. So everyone, thank you so much for watching. I really hope you've enjoyed this video. If you have, please support us by smashing that like button. It's the #1 thing you can do to help us with our YouTube channel. And if you want more resources from us, check out our Instagram account @clinicalphysio. And we're also on TikTok, clinical.physio, if you're looking for resources there. Now, if you want more detailed webinars on the knee, we've got loads on our membership platform, member.clinicalphysio.com, link in the description below. Examples of webinars we have include knee differential diagnosis, knee objective assessment, and knee red flags, as well as loads of others that you can use for your MSK practice. So thank you so much for watching. My name's Khalid. Look forward to seeing you soon here on Clinical Physio.